patellofemoral tractus. These should be reversed. Because the way I teach it, if I teach it like this, I think it's less confusing. Because it's already confusing, okay? And I'll be honest with you, I was honest with you yesterday, that patellofemoral pain is a terrible, terrible term. Because what does it tell you? Nothing, right? So patellofemoral pain is literally pain on or around the patella or the femoral region, and it's not specific to any one condition. Make sense? So that's how we're going to lead off today, and then we'll go back and we'll talk about patellofemoral maltractus. Okay? Make sense? Okay. Of course it does, because you're sort of paying attention. Okay? So, turn it on. All right, so by definition, again, it's just patellofemoral pain. Sometimes it's called patellofemoral pain syndrome. So if it's a syndrome, do you think that patients often have different types of symptoms that go with it as well? It is. So again, patellofemoral pain is one thing, PFPS or patellofemoral pain syndrome is another thing. But just in general, it's just a diffuse aching around the anterior knee. Okay? So did I tell you I hate anterior knee pain as well? That term? I hate it. Right? So you put that together with patellofemoral pain, and it doesn't really tell you anything, right? So I urge you, when you get into clinical practice, to understand that patellofemoral pain or knee pain, specifically anterior knee pain, is a symptom, not a diagnosis. Technically, patellofemoral pain syndrome is a diagnosis, correct? It is. It's an ICD-10 code, okay? So at a minimum, you could choose that, because then you're saying that the patient does not have patellar quadrilateral, does not have a patellar fracture, does not have patellar instability, does not have a lot of other things, and therefore what's left? PFPS. That's when you should use this definition. Does that make sense? So you excluded all the other conditions that it might be and said, nope, it's just one of those things where somebody maybe is not as conditioned, and therefore the patella is having pain for a number of reasons, and we'll talk about that. But it says it right there. Related to what? Overuse and overloading. There you go. What does overuse mean, right? Give a good history and understand. Is this overuse in the sense that this person is a 3-mile-a-year clubber, right? And now they just ran their PT test on reserve weekend, and Monday morning they're having pain? Okay, cool. That's what it's due to. Or is it literally this person's just doing bad, they're doing good exercises in a bad way, right? So what does that mean? HIIT workouts were invented by orthopedic surgeons, right? And therefore, if you're over the age of 35, we invite you to do HIIT workouts so we can do surgery on you, okay? Or do something, right? Legally, right? Makes sense? So again, you got to get to the root of the issue, okay? PFPS is not chondromalacia. How do you diagnose chondromalacia? I said it yesterday. Open the other ear real quick. Or look with your other eye too. Right? Don't look down at your screen. It's an MRI finding, right? It's something going on with the chondro, which is what? The cartilage. Right? So you're either looking at it under a scope image, right? Which by then you've had an MRI, or you are having an MRI and seeing it. Does that make sense? So again, saying that you're able to diagnose somebody with chondromalacia based on strictly physical exam, so history and physical, is, I mean, I'm not that good. So if you are able to do that, good for you, but it's not the way you do it, right? Does that make sense? Now, if you see where the patellofemoral compartment on radiographs, is it safe to assume that they have chondromalacia? I would say so as well, okay? So it doesn't necessarily have to be an MRI. But which test is confirmatory when it comes to soft tissue, chondral issues? It's the MRI, correct? So again, that principle still applies, okay? You see how that the undersurface of the patella looks angry in this picture? Tells you everything you need to know, right? Nope, because the presentation will be very vague. Okay? Enough on that. There's your theater sign. Prolonged sitting causes anterior knee pain. Again, because you take that extensor mechanism, you put it tight, and it's compressing the patella into that groove it normally sits in. You remember the groove I'm talking about, right? That groove that you see on the sunrise view? Remember that? When I was talking to you guys about slopes, geometry, and all kinds of craziness, right? None of which is testable. Right? But what kind of stuff also causes it? Going up and down stairs. specifically more so going downstairs, and we talked about that already, right? With the deceleration that you have to perform, you have the increase in forces to decelerate, right? So you don't just go flying down the stairs. Okay. Climbing stairs, jumping, and squatting. So specifically with squatting, most patients are usually good, I'll pull your cameras up, are usually good till about 90 degrees, so it's usually deep squatting, okay? At any point, should your knee go in front of your toes? Who here does squatting? You do? Okay, should your knees ever go in front of your toes? Oh,
there's a guy out there.
yeah, okay.
It's called knees over toes guy.
Knees over toes guy. All right, you are our favorite patient in orthopedics. Okay, because that's the point at which you put the most force, right? So just as a general concept, again, you guys don't make sure you all this. So how do we teach people not to do bad knee squats? Don't, your knees should never go in front of your toes. If you want to do it, sir, I will make an appointment for you, an open appointment for you in about a year, and we'll just come on in and we'll talk about things. Okay? But usually what they'll do is when you ask them to describe their pain, it's it's kind of a diffuse, vague, achy, right? And they'll kind of draw a circle around the patella, right? Have I ever actually seen that? I don't know. Maybe it's seen me, right? But I'm just saying, they usually just describe it as anterior knee pain, just like that, okay? Put your cameras away, okay? All right, so I'm just not going to do that again without feeling I'm going to fall over. So occasionally there's a history of a direct blow to the patella. We talked about this before. So that's your differential. What's your differential? Fracture, right? So if there's a fracture of the patella, is that technically patellofemoral pain? Yes. So very non-specific again, right? All right. So what are you going to do? You're going to assess gait. You're going to watch them walk, right? You're going to stand behind them as they walk down the hall, okay? And you're going to ask them to turn around and walk back towards you, okay? You guys are talking about gait assessments, I'm assuming, in neuro by now. Okay, so again, they're looking for multiple things, right? It's rhythm, it's symmetry, those are different things, okay? So alignment, we'll get into this a little bit more later. We're talking about knock knees and flat foot, right? Knock knees is knock knees valgus or varus?
Varus.
Valgus? Valgus, right? So making that distal segment goes into adduction, correct? Somebody asked a question the other day, I forgot who it was somebody over there, right? Say, well, how is it abduction when it comes to varus and valgus, right? You have to understand that you're talking about the distal segment going into adduction, right? Not the proximal segment. Does that make sense to everybody? So basically the tibia, okay, that's what goes. So valgus is abduction. Does that make sense? Okay, because the distal segment of the tibia, right, goes out. Good to go? Pause. Okay. All right. Back up. Patella grind test. What is the patella grind test? Just like you do in there, you basically have the patient fire their quad. One way I do it to get the patient to do it, because I raise patients, right? You tell them to do things, they're like, oh, do this. It's like you just put your hand underneath their knee, right? And you say, push down on my hand. They seem to be able to follow that instruction. Okay, so they fire the quad, right? And then you grab the palm of your other hand and you mash down on the patella, right? Make it hurt, all right? Make it grinding. That's why it's called a grind, right? I'm trying to get that grind. It's like I get that morning coffee, right? So, does a patella grind test hurt for most people?
Yes.
Yes, especially if you do it like I do it, okay? The point is, do they have pain out of proportion? Does that make sense? It's not comfortable, right? But it is called a grind test. So if you're afraid to do it, right? If you have a mask on, you can hide your emotions, right? So, but I'm just saying, if you're afraid to do it, then you're not doing a good test. You have to do another test. The other test is called an athlete test. You guys know what an athlete test is? No? Okay, we'll talk about it next week. Because some people look at it as a meniscal test. Some people look at it as a test for patella. Okay, it could be a little bit of both depending on how you execute it. Okay. All right. Anyways, patella maltracking instability. We're going to get into that here in a second. Okay. So when it comes to patella instability, what are we talking about? The patient might have a history of what? Dislocation, patella dislocation. I agree. Okay. So when you're talking about patella dislocation, which side does it normally go out? Laterally, correct? All right, so, and which ligament gets stretched? Medially? Well, I just gave you half the answer. Right? Medial, patella, femoral, ligament. Perfect. That's good. That's good. We got there. We did it Marine Corps style, but that's okay. So patellofemoral, medial patellofemoral ligament, right? So very commonly, again, especially if that amputee falls out, when they have pain where it's supposed to attach, yes, 100%. Okay, but they'll have that generalized patellofemoral pain because again, the patella went out of that groove. Can they shear cartilage out on the underside of that cartilage of the patella, excuse me, as it goes out? Yes, that's what happens. And we'll talk about that here in a second when we talk specifically about disability. What is a J sign?
Sounds like Cody.
Have you ever heard that term before?
J point.
Like an upside down J. Okay, I like that definition. Did you guys all hear that? No? I'm proud, sir.
It's when your knee starts from flex to extension, and the patella goes in the lateral way, like an upside down J.
Okay, so basically the knee, you would say then, what you're describing is in general terms, the patella has abnormal motion when you're going from flexion to extension and in reverse, correct? Yes? Okay, sorry, I couldn't hear your head shaking. Yeah. Okay, good. So let me extend this real quick. I have a good picture, a video of this. Sorry, you're not like a bobblehead, I can't hear it. I wasn't meant to be fun. Okay, we got it to work. Now we'll be able to get the other thing back. We'll deal with that when we get there. All right, so this is patella maltracking. Your description of it, sir, was appropriate. It wasn't terrible. Okay, so this is patella maltracking, right? So
This is patella maltracking, where the patella, instead of gliding smoothly within its groove, shifts.
you guys see that? It's on the loop, right? So, just gonna show over. So you see the patella? Is this supposed to kind of go straight up and down? Right? Does that look painful? Yeah, right? Okay. So somebody in here is like, wait, I thought that was normal. That's my knee. I'm not judging you. Right? Okay, but that's patella maltracking. Okay? Can you see the J? I don't know if I can ever make out the J, right? But the whole point is that there's not a natural glide in the patella going from extension to, flexion to extension and vice versa. Okay? All right, so this is specific, right? Because the J sign goes with patella maltracking, correct? There's no point every semester people are like, I don't understand just the maltracking instability. You would agree that it's not dislocating as it's going from flexion to extension, correctly? Correct? All right, so instability is a whole other thing. Okay? All right, this is literally just maltracking. Okay? Are we good with the video? Let's see what happens when I push this button. There? Yeah. Okay. We got that. All right. So that's the J sign. Okay. Good to go. Is that helpful? Okay. Good. I can't recreate a J sign. I'd have to like lacerate here with the bell. Okay. So, all right. So there's your sunrise view. So again, if you look for dings underneath here, right? Dings underneath this, right? Did you guys learn in radiology what that's called, that sign? No? Okay, of course not. Why would you, right? It's called tooth sign, T-O-O-T-H. Tooth sign, right? Don't know why exactly it's called tooth sign, but that's what it's called, right? Maybe it looks like a bunch of teeth. So what happens is underneath here, there's little fissures. You guys know what a fissure is, right? Deep and wide, okay? A fissure is underneath there. And so I guess those fissures cause spaces, which look like teeth. I don't know. But anyways, you can see little areas of defects underneath there. So if you see those defects on x-ray, are they pretty significant? Yeah, right? Because it takes a lot to see that stuff. It has to wear down pretty far. So then you can assume they have chondromalacia, but you should still get the x-ray, or the MRI, because you have an x-ray to get there. So what's the view you want? Sunrise view. helps rule out malalignment, arthritis. All right, guys, let's get to it. Is this the larger condyle?
It's not.
It's not? I think it is, right? So which one do you think is medium, which one do you think is lateral? Tricky. This is a trick question. I'll never ask you this question. Okay, but you see the slope, right? Okay. Does that groove look shallow? Does it look like it's going to resist much of that motion going side to side there? It's not going to resist, right? It looks pretty shallow to me. Okay, I'm not trying to insult it, right? But it looks pretty shallow to me. So basically, if you have a shallow groove there, right, that's not normal, okay? It's not going to encapsulate or entrap this pulse. So that's what this picture is just showing you. It's a shallow groove, okay? I'm not going to get into the geometry again because people are like, oh, not math again, right? But it's a shallow groove, therefore it doesn't provide that restraint, therefore there could be maltracking and or instability. Are we good? Okay. So if you see that kind of stuff on radiograph reports, that's all they're talking about, okay? Does the patient have a JSON on exam? He does, right? Well, that makes sense because he has a shallow groove, right? But does he have to have instability? Okay. Stick with me on that, okay? Because that's a big turning point, okay? So if it's just strictly PFPS, you ruled everything out, you're like, I gotta choose something, right? ICD-10-wise, you gotta choose something. You've chosen PFPS. What is the treatment? What is the hallmark of PFPS? Physical therapy. Is it sending them straight to orthopedic surgery? Never, right? You gotta do the conservative stuff, okay? Gotta do conservative, because most people tend to get better with PFPS. Okay, so you guys know that the one thing I always tell you guys is that when you're doing knee testing, special testing, and knee range of motion even, do you have to have the patient relax their quads to do those tests? Yes. So guess what? If they have a really loose and not strong quad, right, and tight hamstrings, do you think it could affect the glide of the patella as it goes from flexion to extension? And isn't that what I told you guys to send someone to physical therapy for? To get hamstring strengthening and, quad strengthening and hamstring stretching? Yes, I keep telling you guys, that's what you put in your console, right? So you would assume that maybe in some way, shape, or form, if they have the J sign, maybe that'll improve with that physical therapy. Good to go? So what's our math? You send them there for 6 weeks, they come back, they're improving. Okay, so for another 6 weeks, right? Then 6 plus 6 equals 12. 12 weeks is how many months? 3. Okay, good. And so therefore, most things in ortho, if it doesn't get better in 3 months, you send them to ortho. Make sense? But you don't just send them right away. Don't send me every infantry guy, right? We don't have bandwidth for that. Make sense? I'll treat them and treat them, but I'm just saying, there's going to be you're doing them a disservice by sending them straight to surgery. Okay? Because one of the other things you can do, do you have to send them to ortho to get all this stuff? The patellar pads, knee sleeves, or taping? No. All right? Can physical therapists do taping? Are they better at it than most of them? Honestly, are they better at it than most of those big surgeons? Absolutely. I'm admitting it right now. All right? Because I will tell you that most of our big surgeons are like, that's not my job. Right? But I do a little taping, but I have a background in some of that therapy stuff. So weight loss, obese, in parentheses, I don't even know if that's necessary, but they're just a little bit more pear-shaped than they used to be. Right? Or maybe they've always been pear-shaped. Right? But you can tell them to lose weight. What's my rule? Have I told you guys my rule, or the rule I should say, with how every pound here translates to every pound here and here? I've told you guys that rule, right? So 1 pound here, right? Don't judge me. 1 pound here is 8 pounds here and 8 pounds here. Right? So take the amount of weight they're overweight, say it's 20 pounds. That's a lot of weight, right? It's a lot of weight. So just simply weight loss can improve some of their knee pain, right? Depending on what it is. Okay. Here we go. Operative, discussed previously. That means that we should have done the instability thing first, so we have not discussed it. But if you have instability, what's the treatment that orthopedics does with instability? Surgery. Okay. What is the specific surgeries? Let's go back. I'll talk about that in a second. But maltracking, okay, if you have a certain degree of maltracking, right, and it doesn't improve and it causes a lot of cartilage wear, do we sometimes consider doing realignment surgeries to decrease that maltracking? Yes, but do we understand the difference between maltracking and instability? Okay. Again, that's the reason I'm doing this one first. Okay. Adverse type of treatment, avoid aggressive quad activities until later in rehab period. So what that's basically getting at there is that there is a rehab protocol for PFPS essentially. Is that also in that silver book? I think it's red now, right? But that patient advisor, sports medicine patient advisor book that I gave you guys, is there a handout in there for PFPS? Yes, and there's different phases of it. That's what they're telling you. So phase 1, they're not doing running, they're not doing jumping. They're doing primarily stretching, right? Then in phase 2, they add the strengthening. Then in phase 3, they add what? I taught you guys walk to run progression. You guys remember that? I taught you about getting back to high impact activity. So that's what they're talking about there. Okay? Now let's go back and do this. So it makes sense. All right, so now we're talking about maltracking, okay? So maltracking, kind of where we left off. So that means that there's abnormal motion, correct? Is this where you find the J sign? Yes. Okay? Most common instability, if it is going to be present, is going to be lateral. And what's the ligament again? Medial patellofemoral ligament. Okay? So here's a breakdown, right? This is it. If you're going to study a slide and break it out, say what's instability, what's maltracking, this is the one. Okay? Instability, obvious dislocation or transient dislocation with spontaneous reduction. That means that if you call me and tell me that a patient has patellar instability, they have a history of subluxations or a history of dislocations. That's point blank what it's telling you. Okay? So then is it fair to assume that everything else is essentially maltracking? Yes. Okay? Hopefully that makes more sense the way I presented that. Okay? And there it is again, stairs descending, right? Going downstairs for that deceleration. Okay? Any questions about anything on this slide? It's all kind of repeat. But there's your apprehension test. So how do you do an apprehension test? This is a good picture here. Okay? So you have the leg off the table. Can you do it, in different ways? Sure. The whole point is though is that you have the leg off the table or supported, okay? And you have the knee bent to how many degrees? What's that rule that we always kind of seem to come to as far as bending the knee? 30 degrees, right? So if it's not 90, the answer is 30, right? It just seems like no, right? 30 degrees. So which way are you going to translate the patella, or which way does the wrong leg dislocate? Laterally, right? And so if you go to do that test, if I walk up and surprise a student in the middle of a GI study, right, like right now, right, and I grab their leg and I bend it to 30 degrees, and I go to push it, are they going to let me? No, right? So that's the apprehension of it, not the pain. It's an apprehension test, right? So a positive apprehension test means that they have to have apprehension about you translating them laterally, right? Should you keep going? Only if you want to relocate them, correct? So that's always the rule, right? Yeah, that's always the rule. So there's a video here. I can never get that video to play in class. I don't know why. There's another video there that shows some the J sign. And look at that at your leisure. At your leisure. Okay. All right, there you go. Does that groove look super shallow? Looks pretty dang shallow to me. That's a clear-cut case of not it's not have you dislocated, it's like how often you dislocate. Does that make sense? All right, that's pretty shallow. That's not restraining anything. This is called a lateral tilt right here. Okay? The patella is naturally sitting in a tilted position away from that groove. Does that make sense? So that's actually called a lateral tilt of the patella. Okay? But again, it's our relationship with the patella to the femoral trochlea. Okay? So you see how it says merchant or Lauren views there? Have you guys learned that? No? You never heard that before? So there's all kinds of different views in Ortho, okay? The sunrise view, I will tell you, you will order very commonly. Merchant or Lauren views, that's just something you can do if you really want to get a good look at the patella, okay? Or that trochlear groove, okay? Because there's a view they can do in radiology where they actually subtract the patella. That's called a tunnel view, okay? So you can look right down that groove. But I wouldn't get too concerned about that, guys, okay? Notice how that's not mold cold, okay? So if it's a ligament injury, what's the study of choice? MRI. Good. So what is a patellofemoral arthrosis? Is that inflammation around the patellofemoral joint? Absolutely. That's all they're saying. Okay. But arthrosis, what's the difference between arthrosis and arthritis? Okay. Swelling. Okay. And arthrosis, is that just a generalized inflammation? Okay. So arthritis is and arthrosis is, so a lot of times that's, remember I told you guys this concept of a continuum, right? You can go from arthrosis to arthritis. Okay, so that's really all they're getting at, okay? Because with PFPS, right, or patellofemoral maltracking, both of them, is it just pain in and around the patellofemoral joint? It is. So the degree of degenerative pain change will depend on how long the condition is present. Okay. Bless you. All right, cool. So what's the treatment? All right, acute patellosubluxation or dislocation. All right, Mr. Malone, I scare him and startle him, right? He jumps out of his chair and dislocates his patella. Okay? So do you think that he's going to be in a flex or an extended position when he dislocates his patella? Flex, correct? Do you think if you simply extend his knee, you might relocate? Yeah, you might, right? So some patients just do that. Right? I had radiology call me about a radiology tech who was on break and went to rotate and dislocated his patella. So they had him standing in the hallway like this, with one knee bent, the other one straight, and he had this look on his face of sheer panic, right? And they're calling me on the phone. I'm like, oh, they're calling me about an imaging study or something, right? Because they do like 1 million X-rays a day. You're like, sir, we got this guy with patella dislocated. Like, oh, great. I'll look at the films when they come through, and they're like, no, it's the tech who was shooting your X-rays. And I was like, wait, I'm confused. What are you talking about? Right? And he said he's dislocated, his kneecap is sideways, and I'm like, is he standing in a bent position, like his knee bent? I said, yes, have him stand straight up. And then literally in the background I heard, oh, that feels much better. Right? So I was like, can he continue shooting X-rays? No, I'm joking. But the whole point is you want to know, like, when did the dislocation occur, right? Because I was like, well, it just happened. What's his chances of redislocating in the near future? High, correct? So again, that's what an acute dislocation is. Okay? And why do I mention that? Because people that have chronic dislocations, can they have an acute episode of a dislocation but have chronicity in their condition? Yes. Okay, that's the point. So the way you treat these patients, even if they're chronic, if they just dislocated, you got to treat it as an acute dislocation. Make sense? Okay, good. Because the treatment for it's pretty much goes against what I keep telling you guys about the enemy of orthopedics, which is stiffness, correct? So you want to actually lock them in extension, let things cool off a little bit, right? Let things start to tighten down again, because everything just got stretched, right? So you want things to stiffen up just a little bit, right? Don't remember that with anything but maybe this condition and maybe a few others. But basically, you're going to brace them in extension. The best thing for bracing an extension, I already told you, is what? Is it a knee immobilizer or a range of motion brace? Knee immobilizer. Gotcha. Right? But that's the traditional thought process, okay? But do knee immobilizers, if you had a range of motion brace, is that good enough? It is. The difference is the range of motion brace has a strap here, has a strap here, has a strap here, has a strap here. The immobilizer is just one big salchicha, right? So it's a big sausage, right, where you're just wrapping the entire thing. And when you put that Velcro there, you don't have to worry about each individual strap. So if you're going to use a range of motion brace, you got to put it on correctly, right? Make sure it's snug to the skin. Okay, makes sense. Otherwise, traditionally, we teach providers to use the immobilizers. There's no thought process, right? It just has a long metal shank down either side, going from about here down to about here, right? And it just makes the entire knee enveloped, and that's why it's called an immobilizer. Immobilizing meaning there is no motion expected. Make sense? So that is, it's still technically relative stiffness, but it's just not a lot of motion. Okay, good to go. Enough on that. So what does it say there? Modified weight bearing. So you have the patient on a knee immobilizer, right? The entire thing is enveloped. Can they still walk like I'm walking right now? That's what they're going to walk, right? Do they need crutches? Only if they're weak sauce, right? But if they do, give it to them, right? But they can walk like this, okay? See what I'm saying? They can still walk, correct? You can walk with your legs straight. Now, both of them is going to look weird, right? Right? But I'm just saying, right? They can walk. So you want them weighted in, correct? Is that still going to allow some of that calf pump and decrease their incidence of DVT? Yes, the calf is still going to pump technically, you know. So you want to move it. Okay, if you got to give them crutches, sure. Well, you might. That's why it says modified weight bearing with reevaluation in 2 weeks. So no longer than 2 weeks. You put the knee immobilizer on, the clock starts. Make sense? Can they, if they're laying down on a table and they want to take it down, right, because they're all hot and sweaty, like I have been all week, right? So, and just kind of clean the area, do some self-hygiene, right? Okay, fine. But do you want them flexing the knee in the first 2 weeks? Not unless you want to relocate them again, right? Because every single time that they dislocate, this underside of the patella might shear off. Some more cartilage, some more cartilage, some more cartilage. Okay, so every time you do it, it can cause further damage. Okay, and what is over here, right? What's over here on this side that attaches right back here? What's that ligament called? MPFL. So every time you stretch it out, stretch it out, stretch it out, right? Could it get stretched out so far that it becomes a grade 3? Yeah, absolutely. Right? Make sense? Okay, good. All right. So chronic recurrent maltracking. There's that PT exercise I told you about. What's the definitive treatment though for somebody that has chronic instability? MPFL reconstruction. Perfect. Okay. So I thought that was a better way to bring that to it. And us to it. And then realignment osteotomy. That's the maltracking component of it. Okay. If you look at it like this, you're looking at this as a sunrise view, right? Everybody looks at sunrises like this, right? Nobody looks at it from SpaceX, right? We all look at sunrises like this, right? So that's what we're talking about. But if you look at it from the coronal view, you're talking about the alignment from, we talked about this already, right? What's that bony prominence on the anterior aspect of the ilium? ASIS, okay, that's one of our reference points, correct? So we can use the ASIS and we can shoot all the way down to the medial mal. Does that go through the patella? It does. So we can compare that alignment on the affected side to the other side, correct? And then we can decide if we needed to, could we break some bone, move it over this way, move it over that way, and create better overall alignment. Does that make sense? That's my explanation. You guys good with that? Okay. You don't need to know much more than that. That's the concept behind it. That's why those two things are different. Okay. MPFL will recreate that ligamentous stability, but if you need to do an overall alignment change, it's going to be a realignment osteotomy. Okay. We know all this. Can a patient still have some residual instability even after this MPFL reconstruction? Absolutely, 100%. We counsel them on that, right? Remember, some people are loose, not in character, but in ligamentous strength, right? So if they're loosey-goosey, right, they may get loosey-goosey afterwards, right? So those patients tend to do that. So oftentimes, though, the patients that do have recurrent instability, even after an MPFL reconstruction, is because the alignment wasn't considered. Make sense? All right? So a lot of times, like I said, you got to consider both things, but leave that to the surgeons, right? So referral decisions, red flags, acute dislocation. Anybody who dislocates should get sent to orthopedics, period. Okay? All right? Why am I teaching it that way? Because can you see cartilage on x-rays? No. So what is a patient dislocated? Pretty traumatic dislocation, right? I had a guy, I remember his face, right? I also remember his cologne was terrible. But he was line dancing, right? Line dancing. You look at this dude, you're like, there's no way this dude line dances. This dude was line dancing. He went to do some bippity bob something or other, and he twisted and turned and bloop, he was out, right? So I was like, okay, good to go. I got a call about him. I said, put him in a knee immobilizer, send him to me, I'll see him in the clinic. He came in the clinic, big swollen knee, right? I said, all right, we're gonna continue, we're gonna send you physical therapy, we're gonna do some icing, some elevation, right, all this stuff, right? No motion though, right, for the first 2 weeks. I saw him back a week and maybe just shy of 2 weeks. I could not get that dude to flex. What that dude had done with his line dancing heroics is that when he dislocated a large chunk of his cartilage, boop, fell off. Okay, essentially he sheared the cartilage. When I say mean large, I couldn't get him to move. Is that a mechanical block to motion? It is. I told you, that's not necessarily going to save his life, but you can't walk around with their leg like this forever, right? That's just not practical, right? So I sent him for a more sooner MRI. That was the biggest piece of cartilage in a young, healthy person I've ever seen, floating around the side of his knee. Okay? So we had to go in there, put that thing back where we think it came from, right? Sooner than later, and try to restore some of that congruency there. Make sense? All right? So again, that's why I'm telling you, send all your acute patella dislocations to orthopedics. Because are they going to come, is one of your chief complaints for your clinic going to be ER follow-up? Yes, you're going to get a lot of those. ER follow-up for whatever. The ER always says follow up with your PCM in 72 hours. Welcome to medicine. You're going to love it and you're going to hate it depending on the patient, right? So send those patients subsequently to see orthopedics, okay? Like chronic dislocation, subluxation, good to go, right? But I don't teach the one, everybody gets one rule here. Let me think of it in those terms, right? If you send it to me and it was their first time dislocator, I had surfers in Misawa. Yes, they're surfing in Misawa, in northern Japan. Yeah. They dislocate all the time, right? They just dislocate, come back to see me, no surgery, did the strengthening, did fine, didn't dislocate again for months. See what I'm getting at? Let me make that call. Good to go? Or someone like me. I'll be in retirement. All right, good to go. Why did I spend so much time on these two topics? If there is a topic that people miss questions on in this block, it's this one. Okay? Because people think, it's patellofemoral instability. Is it though? Or is it maltracking? You see what I'm getting at? So you gotta ask yourself that question. Okay? All right. We'll push for a little bit, and then we should push a little bit more, right? But don't let you guys go early today, okay? Oh, all right? All right. That doesn't mean you stop studying. All right, Plica's syndrome. Okay, we already talked about this. We can move. Plica, I told you. Which Plica am I going to ask you about? Medial or lateral? Medial. Okay, because that's the most common, the one that's symptomatic. Plica is nothing more than a fold in the synovium. Okay? Do you have synovium naturally? Yes. So it's a fold in the synovium that can become symptomatic. But I'm telling you, it says there it's usually asymptomatic. All that's saying is that you have plica. It's normal to have plica, right? You can have a plica and not be symptomatic. When you have plica syndrome, that's the symptomatic stuff we're talking about. Okay? So it becomes inflamed and thickened from trauma or overuse. Is it going to be from a lot of running, a lot of bent knee activities, right? You see how I think about those things, bent knee activities, right? For example, Waterman, plica syndrome, Waterman, same thing with prepatellar bursitis, things like that. It just exists with certain patient populations. But the most common is medial plica. So yes, there is a lateral plica. In fact, there's another plica that I won't mention. But the one that again, if you're going to answer a question on pants, the most common is medial, so therefore you should think in those terms. Okay? So medial plica. So where is it telling you right there? It's telling you that that's where it is, right? So is that medial to the joint line, but lateral to the patella? Yes. Okay? So, and by the way, is there not what's the bursa that sits right here? Has that the goose-like foot? Okay, good. But you see what I'm telling you, right? When the description of the vignette tells you where the pain is, where the point tenderness is, it'll be described something like what I described to you. Okay? But will it ever be joint line pain? No. Even if it's medial side pain, it will not be medial joint line pain, because that's not accurate. Okay? Extends from the medial joint capsule to the medial anterior fat pad. What is the medial anterior fat pad? Well, you guys know from that view that we looked at with the MRI, there's a fat pad that normally lives under there, correct? Okay, so with that fat pad there, we're just talking about the medial side of that fat pad. Good to go? Okay. Anterior medial pain, how helpful is that? That's about as helpful as patellofemoral pain, right? But again, this is anterior, but medial. So maybe a little bit more helpful, but still not largely helpful. So it's a plica, it's a fold in the synovium. Can you have that snap, crackle, pop that I tell you guys to always ask your patients? Yes. Okay. And if the snap, crackle, pop again is lateral to the patella but medial to the condyle, but definitely not medial joint line, then you should think more plica than meniscus, correct? Because can the meniscus also pop and click? Isn't that what the McMurray's is looking for? Okay, good. So again, these descriptions are important. Okay, makes sense? But is it directly overlying the patella? No. No, because that would be the bursa, correct? The prepatellar bursa. Okay. You're welcome. Trust me on this. All right. Painful snapping, popping. All right. So at approximately 60 degrees. Okay. There's a picture there. What's straight? 0, correct? What's folded? What's bent to 90 degrees? 90. Duh. Right? So what's in between? Huh? 45? That's what I heard. Okay, good. So then 45. So then 60 is a little bit more flex than that, correct? So usually in that 45 to 60 degrees is where people start experiencing the most pressure to some of those structures in the knee that we keep talking about. And so again, that's that. What do we call that in the shoulder? When a patient has pain from 1 degrees, a certain amount of degrees to a certain other amount of degrees. What's that called? A painful arc of motion. Yes, perfect. So a patient has a painful arc of motion at approximately 60 degrees and a popping sensation as well. They experience a popping sensation. There you go. There it is. So that's your like classic medial plica. Putting it together with their pain is, like I described before, in a very specific location. Okay? So radiographs, you're going to get them, they're going to be normal. Is plica synovial folds? Yes. Is that soft tissue? 100%. Your x-rays are going to be stone cold normal. Okay? Nothing. Then you get the MRI, and you will convince yourself, right? You will try to convince your neighbor, right? You will try to convince everybody in your department, anybody who will listen, I see the plica. Right? I see it, it's there. And then I'll look at it and say, I don't know, maybe, right? So what do I mean by that? How do we actually confirm what? Look at that question mark right there. Is that a plica there, or is that just the way that that image showed up in that particular moment in time? Right? Is that a plica there, or is that the way the image looks? Right? I don't know. But I will tell you this. Plica syndrome tends to be a diagnosis of exclusion. Right? You don't have a meniscal tear. You don't have MPFL. You don't have pezanzeritis bursitis. You don't have prepatellar bursitis. What's left? Patellochondromalacia? You get the MRI, there's no, do you see any cartilage wear there? Of course you don't, right? Because it's not labeled, right? Right? It's not labeled as cartilage tear, but there is none, right? So what are you left with? Plica syndrome. Then you convince yourself, sitting in the dark, looking at this image over and over, that there's a plica, okay? You get what I'm getting with this, right? So a lot of these people exhaust therapy, right? Do they get injections sometimes? Yes, right? But I will tell you this, if you do an injection, and this is a concept I keep telling you guys, right? If you do an injection into the knee and they get 100% relief, is that both diagnostic and therapeutic? Yes. If you do an injection, right, into the synovium, which is the knee joint, right, and they get 0% relief, do you think you're going to have much success with a plica excision? Maybe, but you got to be careful with hedging your bets in that case. Okay. So, but what's the best way? Just go in there, put a scope in there, put one hole, put a scope, put the other hole, put an instrument, and see what you see. Okay? Good to go? All right. Enough on that. All right. So what is adverse outcomes of disease? It is possible to get an erosion of the femoral condyle. Which femoral condyle? Which one do we always pick on? Okay. There you go. We always pick on the poor medial condyle. Okay? The medial femoral condyle. Okay? So it is possible, right? Because is it friction? Yes. And when the knee goes into flexion, can that synovial fold push pressure down on the medial femoral condyle? Yes. Right? So there you go. That's your thought process. Have you ever seen that? I don't know. But like I said, have I seen plicas? I don't know, but have they seen me? Probably more times than I've seen them. Okay, again, tough diagnosis. Okay, right, there it is. The picture is clearly labeled. Number 1 is the femoral condyle. Number 3 is what? The medial plica. And number 2 is the tibial plateau. So that gives you an orientation of where you're at. Would you agree that this is kind of like frayed crab meat? All right, who likes crab? You know that crab when it's wet goes kind of frayed like that, right? That's crab meat, right? So it looks kind of angry and frayed. Okay, so there you go. But there it is. There's the plica. Does that look symptomatic to you? Well, first of all, it's in black and white. Okay, so who knows? All right, but I'm just telling you, that was pretty freaking normal to me. Right, but is there signs of inflammation around there? Does that look kind of frayed and kind of ratty looking? Yeah, so sometimes we'll just take it, right? Just take it away and see what happens. We tell the patient we'll go in there and do a debridement if we have to and see if it gets better, okay? In this case, it's called a resection, right? But debridement works too, right? Are we also going to chew some of this up? It looks kind of like angry? Yeah, probably, okay? There you go. So take things away and hopefully it makes it better, okay? But again, before you got there, there's the injection I told you about, diagnostic and therapeutic. A lot of times when it comes to plica, foot stomp, we will do a diagnostic and therapeutic corticosteroid injection as part of our indication to offer the patient surgery. But if they get 0% relief, we are very careful about telling them that a medial plica resection is going to be the answer. And we might have to do more than just that. Correct? Any questions about that slide? Okay. There's all the risks again, DVT, stiffness, etc. Post-op infection. All right, wash your hands. All right, get your socks. So when are you going to send somebody to absolutely 100%? Right, before you do conservative care, because I told you do conservative care for everybody who suspect plica syndrome. But if they have these things, this specific symptom, what's in both gold there? Okay, instability is always a surgical indication, correct? Especially if that's their issue, right? If that's their issue and they're having instability, we want to talk to that patient. Make sense? Okay. So maybe you don't do a full 3 months. Maybe you do 6 weeks and see how they do. They don't get any improvement. Maybe send them a little sooner. Is instability going to get better with physical therapy? Not necessarily. Is their range of motion going to improve? Their swelling going to go down? And their strength going to get better though? Yes. But not necessarily the instability. So be careful when you're talking about physical therapy. Be realistic in your mindset about what kind of improvements the patient will actually get from physical therapy. Make sense? PT can't cure everything, right? I had a physical therapist tell me that PT can't cure ugly. So I agree with her. Okay? All right. So let's take a quick 5-minute break. If you guys are okay with that. Okay. Refresh, stand up, right? Put your pen notes on your GI notes. Okay. And then we'll just hit this one topic and then we'll be done for today. Okay. Sir. There's so many things. Next week, when my head is fully clear, I'm going to have to address many future referrals. But this week, I'm safe.
Yes.
Yeah, but you can't really ask them.
That was the first movie I saw with my now wife at the movie theater down in the movie center. We were both like nothing. 1997. Yeah, but you know what movie it beat out that was a better movie still? Still a better movie, but it beat it out because everybody got the rubber star ratings.
Overall top like high school. You said there was a. No, for sure that was. He said there's a movie that was better than should have.
Oh, yes, sir.
If he's talking about it, yeah, that's gotta be real. No, we're right. Where'd you get
It's like a nice. It's on your way out, on your way back.
You just have to put it like 400 meters from your house. That way when it hits, it just doesn't hit your house. I wouldn't bet that. It also doesn't strike very often because
My grandparents' house, they had 2 trees that got hit.
I asked around if it was anyone to know what's anything on their own.
Oh, you stole it? Damn, that's crazy.
You can't steal it. It was left behind.
I don't know. I've been seeing like missing signs all over the campus that says missing, standing desk, reward, cheap sandwich and found.
Like, how is she? When you said you had a very nice place, I was like, how are you
Mayonnaise or something.
I was gonna be nice, but apparently I can't be nice to her.
You know you put them on.
I did. Well, I thought it was.
No, not that. You were coming in the gate, like, into post 2 days ago, and you confronted me.
You cut someone off every day already.
Listen, you can't see my turning signals. That's
You
all.
didn't have a turning signal. I just went.
I use turning signals every time. Listen, Florida.
I mean, I know people in Miami drive, so I can't really complain. I'm just Miami's another piece.
I drive very carefully.
You drive
Maybe you're speeding.
Everyone has a story about you.
You drive the.
Everyone talks about you cut them off.
She drives the Miami Cuban.
That's not true.
So let's not tell stories.
Alright, so you guys ready to push? And then more importantly, get out of here. Yeah. Right. So I try to hold to that rule, just so you guys know that at 10 till I give you a break, right? Regardless, because if I don't, there are studies out there, guys, that say after a certain amount of time, you only retain so much, right? After even more time, you retain even less. And when you get down to about 15 minutes, right? Regardless of the fact you're studying GI, you don't remember much at that point, right? So the retention rate is, so the risks outweigh the benefits. Does that make sense? So even standing up for like 2 minutes and getting the blood flowing to your head again, and in this case, sort of my lighthouse member in this class, right, who was nodding and just about broke their neck, right? Just get up, get the blood going, it increases retention. So that's why I put you on break to bring you back, talk to you for 10 minutes, and send you home. Good to go? Because PCL injury should come, the discussion should come shortly after ACL, right? Right? Because if it doesn't, then the correlation kind of gets lost, right? So I want to cover that today. So bear with me for PCL, and then you'll be on your merry way, okay? All right, here we go. All right, so PCL. So PCL is a posterior cruciate ligament. Cruciate, again, meaning X marks the spot. Where's the spot? Intra-articular. Both components of that cruciate are intra-articular, okay? There's a good actual representation there, okay? So you would agree that this is the posterior aspect of the knee, correct? This is not the anterior aspect, and that area where the ACL inserts, right? So the PCL, although it makes an X, right? It makes that cross and goes into the posterior aspect of the knee. So therefore, it stands to reason that if it's going to provide restraint against motion, which direction would it provide restraint against? Posterior translation, correct? All right, good. Tears with actions that force the tibia posterior. Okay, so generally speaking, when it comes to this, right, most LCL injuries, you can live, right? You will live. Most patients will do just fine. And especially when it comes to isolated PCL injuries, right? PCL injuries that are isolated, meaning it's the only injury they have, right? They can function at a near normal level, okay? Makes sense? So you can send them to orthopedics, that's fine. Well, we'll take a look at them. But are we usually going to try a course of physical therapy if their only complaint is primary isolated PCL injury? Yes. Okay. Remember I taught to you guys before though, and I want to take a minute, that's why I want to talk about this real quick. PCL injuries and PLC injuries are not the same thing, right? If you don't remember that slide, now it's being recorded, and you're finally watching, right, on Monday. Then you'll be like, oh, I need to go back and look at that slide and what he was talking about there. Because PLC is something completely different. If you have a PLC injury that's associated with a PCL injury, is that significant? That is more significant. That is not, by definition, an isolated PCL injury. Enough L's and C's? Okay, good. All right, so what's the most common pattern? Right, there's 4, but what's the most common? And more importantly, for some of you, what's the most common thing that they test you on the pants? That freaking dashboard injury, right? Your patient was riding a passenger on the passenger side, as a passenger on the passenger side, yes. And then they came to an abrupt halt, otherwise known as hitting another dude or another person, okay? And their knee struck the dashboard, and therefore the dashboard created a posterior force that translated the tibia posteriorly. Whew, that was a lot. But that's it. That's a dashboard injury. Okay? Could anything else that could cause that kind of moment, as we discuss moments, right? Moments, not general touch moments. I'm talking about moments as in like a force, right? A motion, right? That's where anything that can cause that type of pattern can cause it, okay? And cause that posterior. So what are the other things? Fall to knee with plantar flex foot, okay? Everybody knows what I mean by plantar flex foot. We understand that, that a plantar flex foot is not the same thing as a plantar flex ankle, correct? Okay, all right, good. Remember that from compartment syndrome? Where it was a trick question where it said plantar flex foot versus plantar flex ankle? So hopefully we got past that, right? So it's a plantar flex foot, okay? All right? So there, and then is the other one a pure hyperflexion injury? Yes. Okay? Then the unicorn is the hyperextension. Okay? That tends to be the one that you really only see if there's something else there. Does that make sense? Okay? You really only see, and then it says it right there, after ACL ruptures. So does it, by definition then, ladies and gentlemen, does that become a multi-ligamentous injury? Yes, so you'll have multi-directional instability, but of the knee. Okay, good to go. Feelings of instability, okay? Do they have the feelings of instability immediately following the injury? Maybe, but does the knee swell up pretty good? Yeah. So you may actually test it, right? And it feels pretty solid to you, okay? So again, you gotta wait for that swelling to go down, right? Diffusion, limited range of motion within 24 hours after injury. That's all they're saying here, okay? All right, there it is. There's the dashboard, okay? There's the dreaded dashboard, all right? So it caused that posterior translation, all right? So when you're reading these scenarios, get a sense of, okay, I think it's a PCL injury, but is that the only thing they're describing to you? Make sure you read the physical examination findings, okay? Good to go? All right, what's the most sensitive test for a PCL injury? Okay, well, let's not get that confused though, because is the most sensitive special test, excuse me, for a ACL injury the anterior drawer? Okay, good. Don't get that confused, okay? But again, even though it's the most sensitive, right, it can be of limited utility, right, bless you, of limited utility within the first couple of days because the amount of swelling is present, okay? Good to go? All right, we'll talk about here in a second. PCL sag, does that look like a sag there? Yeah, sag. Not Screen Actors Guild Award, right? It's sagging, okay? So when you're talking about a sag, like that's pretty pronounced, right? Well, sometimes is it beneficial to take, so pretend I'm standing at the head of the bed, the foot of the bed, right? I need to hydrate one. The foot of the bed, and you have both knees bent at 90 degrees, and you're looking at them like a sunrise, right? So the top of the patellus, right? And you see one sagging compared to the other. Is that also a sag sign? It is. Okay, and I'll show that in lab. If you didn't get it, I'll show you that. Okay. But again, sag just means there's a sag, right? There's different ways to see. If you see that sag, correct? Do you need to lift the knees up and see if it's sagging? It's sagging. Yeah, it has declared itself. Okay. All right. So, but it's important to rule out other ligamentous injuries. When we're talking about ACL collateral ligaments, so MCL, LCL, it is if it's a multi-lig injury, right? But what they're getting at here is multi-lig injury that causes dislocation. Is that limb threatening? 100%. Right? So you need to get a good neurovascular exam and do an ABI. Okay? There's C claudication section for details. Do that at your own leisure. But what's normal? What's abnormal? I should ask it that way. Less than 0.9. Okay, 0.9. It used to throw the 0 in there. Okay? All right, radiograph. Right? So if you have a pull, right? So we talked about where it attaches right here. Is this what I'm pointing at right here, bone? Right here, is that bone? It's brown, so yeah, right. Should be white though, right? But in that case, it's bone. So if that pulls right off the bone, is that called an avulsion fracture? Or an avulsion injury? Yes, that's all we're getting here. You're looking for a bone avulsion, okay? MRI, right? MRI is really honestly just to make sure nothing else is going on, and then get a sense of like what's left. Okay, does that make sense? Right, because I told you that there was reconstruction and repair, correct? Yeah, so you got to figure out what's left too. Okay, what else is injured and what's left. Okay, everybody sees the PCL injury here, right? 100%. If I give you a picture on test, you're good to go. Right? Of course you are. Pause. Yes, I won't add the red circle. That's cheating. But I will tell you that that's pretty obvious. Does it look like there's a little white stripe in the middle of this black line here? Yeah, it's a little white kind of divot stripe in there, right? So it looks like all those fibers are not running in the same orientation. Does that make sense? That's really all I'm trying to illustrate, okay? This is not an easy thing. PCL injuries, identifying, especially, guess what, in the setting of multi-ligamentous injuries. Okay, but again, did somebody looking like me add the red circles? Yes, because I don't think it's intuitive unless you know what to look for. Okay, find one then. So what's the artery? What's the nerve? Tibial nerve? Okay, good. Ooh, almost blacked out. I was waiting for something that got real quiet. All right, so when we're talking about these things, no popliteal artery, no tibial nerve, okay? Instability, duh, right? OA, right? Does it look like the knee's gonna move normally? Right? Yeah, no. Even if you put that back where it's supposed to go, it looks like a little arthritis is coming. Right? So again, do we sometimes start thinking we have to provide stability to put better mechanics in place? Right? Better knee motion? Yes. And I know it's a flippant way of saying that, but you have to understand, when it comes to the patient being able to ambulate, if they have multi-directional stability of the knee, that's a big deal. Does that make sense? Regardless of whether or not those arterial issues and those nerve issues are addressed. And by the way, does it put them at future risk for repeat dislocation if they don't have stability around the knee? Yes, right? So we will oftentimes tell the patient, highly recommend you get surgery, okay? Good to go. All right, recurrent instability, obviously get surgery, okay? PCL reconstruction's the way. Combined injuries, you gotta take care of all the injuries, right? But what does it say there under isolated PCL injuries? Is that under non-operative? And so again, in your sense, right, you can send them to some physical therapy if they only have a PCL injury, right? And they're not really, because I told you, didn't I tell you that they have near normal functional level? So they won't really have too many issues, right? Unless they're high impact, if they're jumpers, right? If their job requires them to wear certain equipment and carry heavy loads, maybe they'll have issues, especially when they're, was that a sneeze? Especially when they're flexing, right? Yes, right? It puts them more at risk, right? But what's a way we can stabilize their knee with a certain brace that's custom fitted? Is that called a functional brace? Yes. So we can give them that brace and they do better. That's another way to kind of say, well, maybe not surgery right away, do some physical therapy. Quad strengthening, hamstring flexibility again, right? Oh my goodness, look at all the anchors there. Oh wow. Is that like a bunch of different ligaments that were reconstructed? It looks like it to me. So if you see someone like this, right? Let's see, I ask this question every single. If someone presents like this, but on a physical exam they have no instability, do you send them to ortho right away? Who said yes? Who said that? Only if you want a phone call. Alright? Because what am I going to do? I mean, look, there's the Lord's work has been done. Right? They have no instability. Right? I told you the rule, pain, instability, or pain with instability. Their only complaint is pain. Do you send them right to ortho?
Always.
Yes, I'll find you two seconds. Think about it, right? Just think about it, right? So even if you treat them, you do good treatment, what could you injure? The arteries, right? The nerves, things like that. I'm not going to read this too, right? But this x-ray is hilarious to me because people are like, ortho's going to fix all this. Like, it's already been fixed. It's all intact. The exam tells you that, right? That's why you don't treat x-rays, people. All right? So, all right, here we go, red flags. Neurovascular compromise. So do you think if somebody has a knee dislocation and has a vascular compromise and a nerve compromise, that ortho's going to fix the vascular and the nerve? Nope. We're going to stand there and say, good luck, vascular surgeon. Let us know if we can go in there and do the real work. So we don't need to say that, right? But we just stand there and wait for them to fix, to stabilize all that, right? And they're kind of standing by when we start doing our thing too. But more commonly what happens, you relocate the knee. Remember we talked about external fixation? Aha! We talked about external fixation, you can use that to temporarily stabilize and then come back and do work later, right? We talked about that. So maybe the vascular guy does his vascular stuff, the nerve guy does his nerve stuff, right? And then we put an external fixator on there and come back and do the multi-link stuff later. Makes sense to me? All right, you should refer that patient. All right, good luck, study.